Hello and welcome to Devex's coverage of the World Health Assembly. This year is obviously a very important year, given what's happening with the global pandemic of COVID-19. And I have two people to help us think about what that pandemic has meant and where it takes us in the future when we think about the future of health systems. I can't think of two better people to give us this broad view and to point us in a new direction than Agnes Binagwaho, who is the Vice Chancellor at the University of Global Health Equity in Rwanda, and was, of course, the Minister of Health of that country, along with many, many other accolades and affiliations that she has, well known in our community here at Devex, and Prashant Yadav, who has also many affiliations, but is with CG Dev, the Center for Global Development, of course, and INSEAD, has worked with the Bill and Melinda Gates Foundation and others as a leading expert in the area of global health supply chains. So really eager to get into a discussion with both of you. Maybe we could just dive in on this issue of vaccine manufacturing and see where that takes us in our conversation, because we are right in the middle of big conversations on this issue. Prashant, you had a piece in the New York Times just a couple of days ago arguing that we need to really rethink the way we manufacture vaccines and where we place it. One of the countries where you said maybe a key hub should be is Rwanda. So maybe you could just dive in on where do you think we're going to go after this pandemic when we rethink the global health architecture and systems and where vaccine manufacturing fits in?
Yeah, thanks, Raj, and honored to be here together with Agnes. And I think the key takeaway, what we've learned is a dependency on global structures alone for manufacturing and purchasing is useful, but not always sufficient. And we need perhaps multiple lanes in how we run the supply chains for health products, vaccines being one part, but also for medicines, PPE, other health products. And by multiple lanes, I mean we ought to think about some portion of the manufacturing occurring regionally that can cope both with short-term demand that may come up during the times of a health emergency or an outbreak, but in routine times, it could serve other more routine needs, and couple that with purchasing from long supply chains for items where we have an established and also geographically diverse source of supply, where efficiency and cost are really important. And when we are thinking about the large cohorts in a country's population for routine immunization or for routine treatment programs for chronic diseases, then we may have to think about where can we manufacture that at such a large scale that we get the lowest prices. And that combination hybrid strategy is what we are seeing to be effective both for current pandemic, but also for being better prepared for a similar.
Well, for the next pandemic, but also for just, as you say, routine health needs in many low and middle income countries where vaccination is still a challenge. I think there's two issues coming together here, Agnes. One is you have the crisis in India, where there's such a massive manufacturer of especially AstraZeneca vaccine, which is meant for many of the countries in sub-Saharan Africa, and they're now stuck without it because India says we're keeping the supply ourselves for understandable reasons, but it's creating this huge bottleneck and challenge. And then we're all, waking up in a way to the idea that only 1% of vaccines for routine vaccinations in sub-Saharan Africa are produced there. So we're really starting to maybe rethink this system. And you've been thinking about this for so many years and studying it. What do you think we should be doing differently from here?
Everything differently. First of all, starting to believe that Africa has not enough capacity. The world has enough capacity, and there is enough plane and people to share and bring the capacity here. We have Cuba, we have China, we have Russia, we have how many countries in Europe and America, and I'm sure in Latin America also, who have scientists who can come in Africa for a couple of years, work and transfer capacity to African. Having the capacity of producing vaccine in Africa doesn't mean that we just want Africa in. Just doesn't mean that we just want a country to lead it. We want a regional effort with a global solidarity. And saying the contrary is just finding excuses not to make it. When we need to save life with peacekeeping, the world put all nationalities together, they put them a blue hat and they send them where there is a problem. We should do that for vaccine and scientists. Capacity is not an issue. Electricity, the continent can solve it because they can come together to divert electricity to produce. And as Pasha said, not only for COVID, COVID shows us that we need to do that if we want to survive the next pandemic, because Africa will be the last to be served. India shows us the problem now. And I'm not against India. I'm against the European and I'm against the American who just block this avenue. Second, saying that we understand so many problems, security, electricity, hesitancy, all those are fake reasons. The only true reason is the lack of willingness to make it happen.
You know, it's interesting in Prashant's argument, there's a lot of realpolitik involved because he's saying, let's move manufacturing from big countries like India, which will have an incentive to keep the vaccines in a crisis, to small countries like Rwanda, where if you can produce a massive number, more than your population could ever need, then you can export it to your neighbors. And one thing this pandemic has shown us is, of course, we knew about vaccine nationalism before, but boy, the way countries have locked down on their PPE, on their treatments, their diagnostics, their vaccines. There was a system, the WHO, the ACT Accelerator, trying to get past this. How do you assess that system? Is COVAX, ACT Accelerator, are the systems that have been set up now to address this sufficient? Is this the way we should be looking at the future?
COVAX is not funded enough. COVAX is a pretext for the rich country to sleep well at night, pretending they have done something. No, they did. Vaccinated 1% of a population is ridiculous when we know we need 60% minimum to have herd immunity, minimum. So pretending, we should stop to give room for pretending. Let's go for real thing. COVAX is not working.
What do you think, Prashant, about COVAX? What would you do with COVAX from here?
So I think COVAX started with the assumption that if we have money and pooled demand from a large number of countries, then we will be able to buy and fulfill that demand. The reality they find themselves in is it's not a technical problem, it's a political problem. And that political problem is that on one side, you may say, yes, they didn't raise enough money. But even if they have more money, there isn't much available in the market to buy. What will they buy? Because all of the supplies have already been taken up. So I think the next phase has to ask, in my opinion, two questions. One is, we cannot solve such problems without expanding manufacturing capacity. And if there is more manufacturing capacity, then yes, COVAX will be able to buy more, distribute more. But then the positive things that have come out of this, and this goes back to my earlier comment on multi-lane systems for procurement and distribution, that the AU organized itself through the Africa Medical Supplies Platform and was able to negotiate for members of the African Union quantities of vaccines which otherwise would not have become available to AU member states. And that effort is in many respects commendable, that you've organized and brought together a group of countries and said, we will create something which will take our common market and go to manufacturers, use our ambassadors and people who have the ability to connect directly with the executives of the companies and say, here is what Africa needs. If you want to work with us, this is how you work with us. So I think that's a positive development. And COVAX and such an initiative can work together. I mean, I think we need to think about at what levels do we need to coordinate globally? And that is information about who's buying, who's manufacturing, how much. For that, we absolutely need to coordinate no matter which mechanism is used to purchase. Purchasing and giving the actual purchase order could be done through COVAX, or if a group of countries creates its own arrangement like the AU has done, that's great too. What can be tricky though is if every country starts to go out on their own and start saying, okay, let me find what I can get for myself. And that can fragment the market into an equilibrium which will hurt everyone.
And where do you think IP fits into this, Agnes or Prashant? This has become a big debating point, a political point. Is this a key issue when you think about that future health system that you want to build? Should there be the vaccine manufacturing capacity and a system for licensing the IP around emergency vaccines? How do you think about that issue?
I think that the reward of scientific finding should be recognized. But we also, the public good should be. We all do that for human. And all those factories did that with taxes of individual like you, like not like me, but like many people in their country. So they should give back to the world what they receive. But it's not that if you come and do a factory in my country, I should steal you. No, come and do the factory and let's produce enough. Like Prashant said, we don't have enough. Even if the world became reasonable tomorrow, we don't have enough because of the history, that it's a colonial history, but also a lack of trust in Africa that didn't develop the capacity of Africa to produce what Africa is needed. And what is requested here, it's not a country doing everything, it's the country working not alone with the continent to do and produce what the continent needs today and be ready for tomorrow.
Prashant, where do you think this issue fits in, and when you think about the future of this?
So I think often what I'm seeing in this debate is that we are confounding the immediate with the medium and the long term, right? In the immediate term, we need to solve the problem of having more manufacturing capacity. If it can be done quicker in existing sites, so be it. But I personally believe that it can be done quickly, at least in a few additional sites, such as what we're talking about, in Africa, in Rwanda and Senegal. And if it's done quickly enough there, it may require the company who developed the process, who essentially mastered all the little steps in making the vaccine, to voluntarily say, I want to send my team to help the new site get up and running as quickly as possible. The fastest pathway to get something that is high quality, efficacious, process consistency will only occur when the originator company which developed the product says, yes, my team which has mastered the process will transfer that know-how. In the medium to long term, opening up IP to additional countries creates the opportunity that people innovate in very different ways. We think of innovation in sometimes a myopic lens of what happens inside a biopharmaceutical company, but lots of things happen when people are trying new things with it. So in the medium to long term, yes, IP waivers can help. But in the short term, I think it will come down to how can we create technical know-how transfer from the company which has developed the vaccine to additional sites. That may not necessarily require an IP waiver. That requires a stronger willingness on part of the company to say, yes, we'll do it. And secondly, we have to also acknowledge that some of the companies who've developed vaccines this time are not the ones who have a big staff or presence across the world. One company in particular, for example, is a relatively new biotech. So can we create a global enabling structure for them to say, I don't have to send my own staff. My staff can train somebody who can then go and create this capability in multiple sites.
It sounds like
the responsibility is not for the company.
A new institution.
Yeah, that is a responsibility for us in the global collective, not so much for the company alone.
And we have as I said before, we have skills in Cuba, China, Russia. So we can ask globally for the right people to come together and start. And I agree with Pasha. This has to start now to be productive in a couple of time. But now we have sites that are capable to produce more vaccine, and they are not allowed to. It's a crime against humanity to let Indians dying like that without trying to give them the capacity to produce vaccine for themselves. Most sites.
Agnes, let me ask you, because I started this conversation talking about vaccine manufacturing and supply, because that is very much where everyone is thinking now. Is there a chance we will learn the wrong lesson coming out of this pandemic and kind of go back to our old ways of vertical thinking, right? Now it'll all be about vaccines instead of thinking more broadly about the health system, healthcare workers, thinking about maybe cold chains or thinking about diagnostics. And are we missing a chance for a different vision, or what is your vision coming out of this pandemic? What should it be?
Like usual, human species is an amnesic species. We are not even now understand which country have done well and why, and countries who have done badly and why. So we have seen now that a country like Rwanda, where with $820 per capita, we have managed to stop the spread of the disease by, before the pandemic, building a resilient health system for the population, focus on decentralization and bring the care where they are, focus on multidisciplinary work, and focus on policies, law, and plan that are focused on the vulnerable. And this is what we create, what we call a resilient. We will see that, but I hope the world will learn about that. Also, the fact that nobody really questioned enough all those metrics and projections where it will go well and why and how, and help countries to be prepared because their projections are wrong. The global security index is so wrong. That this institute should close, go to retreat, revisit his book, and come back with new knowledge.
And those risk profiles make a big difference because they determine interest rates and investment in a lot of the lowest income countries in the world.
And Prashant, invest in the right thing, not invest where New York, London, Washington and Brussels believe we should invest. No, the lack of trust in Africa and the lack of recognizing what is going well in Africa, even European countries, there are thousands of people who die wrongly in Europe.
Prashant, what are your thoughts about where we should go? What is your vision of the future health system based on what we've all just experienced in this pandemic?
Yes, I think you're right in pointing out that there is too much attention on vaccines, and I think we ought to think about system levers, not just very verticalized one intervention. Alongside with vaccines, we have tremendous opportunity to do something differently in diagnostics. We can do a lot more diagnostics manufacturing regionally, for a variety of different diseases, pathogens, and that is advancing and has advanced due to COVID, including in locations in Africa. The second is that a lot of interventions which were considered to be things which are solving one problem. Examples are, the work with the drone company in Rwanda and Ghana, Zipline. We assume though it's
Agnes
solving one
knows
problem.
Very well. I think signed the MOU for them to operate in Rwanda.
Now you realize by investing in an innovative systems improvement platform, you get the benefits of doing contactless PPE delivery, even vaccine deliveries to smaller sites where it's harder to deliver using a truck. And all of that helps us realize that system level interventions are a good bet because they can quickly pivot and help us when there is a health emergency. Another example is a company in Ghana called M-Pharma, which is pivoted and started doing a lot more private sector diagnostics to complement what the Ghana Health Service does in terms of diagnosis. The group that Agnes and others in Rwanda promoted called Babel, which allows teleconsults and other things, triage using technology devices that helps in triage. So I think those system interventions are what our focus should remain. We have learned that the Venn diagram of overlap between system interventions and how much benefit they create, both for vertical programs and for health emergencies, that overlap is much higher than what we have imagined in the past. And COVID has demonstrated that overlap very, very clearly. So when we go back and reflect on this, those are things that we should keep in mind and remember.
Agnes, we have to wrap up. I want to get a final thought from you.
So I just want to say that I totally agree with Prashant, that what I have seen in my country and other country where we had studied what countries has continued to keep ordinary primary care and ordinary specialized care efficiently during the pandemic. Those are countries who simply implement the strategies of creating and managing and repairing a resilient health system. So you don't need to invent anything. You need to be capable to create a system that will respond to any threat. Because you don't know what is the threat of tomorrow. So create the system that's what I call, and we all call, resilient to day-to-day services for all age and any emergency that it comes, because you wake it up in a minute, the emergency before it's killing your people.
And I'll just underline something you both said, which is the pandemic has shown us how people can innovate and they can rise up to a challenge and they can move fast. And if we can set up the systems that allow that.
Absolutely, Babel, we have done e-health. Even locally, not only with through Babel, we have done e-education to keep education. We have done GPS on all the track to continue the transport between Tanzania, Uganda, Burundi, Rwanda, so that we can follow the track and even see where the positive truck driver have stopped to pee. We can go and do contact tracing around that place where he just went out of his car for a biological break. And we can do that. The drone, we use that for more than 5 years. Robots to go look at, give message, take temperature, take blood pressure, so that, and report also. It's the robots are reporting more easily on the follow-up of patient than a tired, insufficient health workforce, and it's so good. So there is a lot of innovation, and that should be used on day-to-day basis in the health sector we are going to have after COVID. COVID is just a step. COVID is just a wake-up call. It's just a disease like plague, like anything.
Well, I want to thank both of you, Agnes Binagwaho and Prashant Yadav, for giving us such an interesting look into where this may take us in the future and where we should prioritize. And I want to thank all of you who are following along here during Devex's coverage of the World Health Assembly. Be well.